Hello students, my name is Moon and this is IS151 Health of the Nation, a class in Queensborough Community College, and this is Lecture 5 of Communicable Diseases. The purpose of this lecture is so that you can hear it in audio while you follow along with the slides in visual. To get the slides, as always, download it from your Brightspace page. We're doing communicable diseases, and that means infectious, or when one person can give it to another, and it's not because of heredity or any other effect like that. It's between one person catching a microbial infectious agent from another. The next lecture is non-communicable diseases, which is going to be chronic diseases, but that's for another time. I sold this class IS151 as an introduction to public health concepts. I teach another class called HE102 where it focuses on introduction to personal health, and that would be a focus on clinical health, which is how to take care of an individual. Now, how do they avoid getting sick? And then what can they do when they do get sick? But since this is an introduction to public health concepts, then we're always going to look at it from the point of view of a public health official. For them, their main goal is to be the most good for the most people. We can't treat everybody to the full extent of what's medically available because that'll bankrupt not only the budget of this agency, but could be the entire nation. No, instead, we have to do what we can to treat as many people as possible within the limits of our resources. The best way to achieve that is to find the weakest link in what's called a chain of infection, and that's going to be transmission. To interrupt the microbe from getting from the infected person to somebody who's not yet infected. But as a public health agency, they also have to know what's going on. You can't fix something until you know how something is broken. And so you can't address the needs of the community or the general population until you know what's going on, what diseases are spreading in the population, and where are they spreading it, how they spread it, and that's surveillance. When they choose surveillance areas and techniques and tools, then they have to pay attention to risk factors because they can then focus their efforts on those groups of people, the demographics, the regions that have the highest risk factors. And that's more efficient economically, practically. And then risk factors often have to do with social and environmental conditions. An agent is the thing that must be there so that the disease can actually happen. And it's not as obvious as it sounds because we'll get into the differences of what is or isn't an agent. An agent in the medical term also applies to non-infectious, non-communicable diseases, but we'll deal with that in the next lecture. For infectious communicable diseases, the agent then is the microorganism. This is slightly different from the word antigen. If the agent is the microbe, the germ, the virus, the bacteria that must be present for the infection to actually happen, then the antigen is the part of that microbe that your immune system recognizes. And that's an important difference because it's the antigen that stimulates the immune response. And then I said the word bacteria, viruses, and parasites. I'm not going to read this slide to you. You can pause. And knowing the difference between every one of these is not actually in the scope of this class. We're talking about public health efforts. What does a microbe want? A living organism that's trying to grow inside your body. Well, you know what? The microbe wants the same thing that you and I want. A place to stay, enough to eat, and somewhere it can grow the next generation. That's all, same as us. But the problem is that where they're trying to get the things they want is inside our bodies, and that's going to be a problem because the things that they want are the things we want for ourselves. You can't have it, this body is mine. So there's a non-negotiable point. And that for these microbes to continue growing inside our body, create a place to live, to create a community, to grow a large multi-generational colony, well, that's a non-starter because we kind of need that. The resources, the space that they're using up, and so sorry, but no, you can't do it in my body. So the immune system is in charge of detecting these microbes as they try to set up shop. That means the microbial organism is trying not to get detected. In fact, the more successful ones are able to avoid the various cells of our immune system, such as white blood cells, who are patrolling our body and trying to detect them. In that case, what are all these things? Inflammation, fever, mucus, pain. Why does the microbe cause these things, which is the sign that we're sick? Well, the plot twist is that no, the microbe does not cause these things. The microbe is trying not to cause these things. It's our immune system that causes these things. The immune system responds to the detection of an intruder, an invader, by starting inflammation, which is swelling, redness, fever, mucus, pain, even though as undesirable as pain may be, pain is an excellent alarm signal. If the body tries to just tell your mind, excuse me, pardon me, sorry to interrupt, but I think there's something bad going here, then if there's something else more interesting, such as a puppy video, or you're trying to focus on your studies because an exam is coming up, then you can easily ignore a very timid email from the body. But if the body sends out pain signals saying, I don't care what else you got going on, but you need to pay attention here. There's a problem here and you have to deal with it. That's pain. So pain is a great alarm signal. All of these is caused by the body to initiate the immune response. In that case, why do we go to the drugstore and specifically get drugs that reduce inflammation, fever, mucus, and pain in our bodies? If they're so good for the body to help fight off invasion, then why are we trying to suppress it? And the main reason is we live in the modern times with a modern medical system. So even though we still kind of need these, we don't have to have it if an infection continues. Why am I having a problem here? If the infection gets worse and worse and worse, then we can always go to the hospital or to the urgent care clinic, the one over at the strip mall. Then the doctor will give us antibiotics or antivirals or antiparasitics, and then we can take care of that. And then if it's serious enough, then we can be admitted into the hospital for next line therapy. So until the infection gets that bad, these symptoms, inflammation, fever, mucus, and pain, are inconvenient for sure. It does interfere with studies, with work. And so when we haven't got time for the pain, as that commercial goes, then we take these medications over the counter from the drugstore. If we were trapped on a deserted island with no modern medical system available to us, then we'd rather not suppress these. Pause here and read, and then hit play when you are done. Your immune system, then, of which the white blood cell is just one type of immune cell. There are many, many others, but it's an entire textbook in itself. And so I will spare you that kind of detail. Anyway, we can break it down into two major kinds. There's the general immune defense and a specific immune defense. The idea is that the initial response is general. The body doesn't know what it's dealing with. It just knows that this invader does not belong here. So it'll ask, let me see your papers, let me see some identification. And when the invader cannot show the self, non-self protein, then it will be attacked, no matter what it is. It can cause some complications, by the way, when that happens. But anyway, a piece of that is sent off to headquarters and analyzed and identified. And then once the body is able to figure out exactly who it is and their attributes and sort of and a dossier, I guess that's how the criminal justice system calls that, like a create a file and like the strengths and weaknesses and the and how to identify it for the next time, then a specific immune defense can be launched. And these cell types actually are coded so that they look for this one molecule from the invader and nothing else. I like the analogy of police. The police officer in uniform that's walking his patrol is the general in the general defense. They stand at the corner or on their beat, and if anything goes wrong, then they respond. But if there's been like a string of murders and they've all been tied to a single individual or actor, and then a detective and a investigating team is put on the case, and now they're looking for this one person or this one group of actors and nobody else. If this team is walking down the street from coming from lunch, going back to the office, and there is a bank robbery happening across the city, they will not respond. That's the police's job. They are trying to track down this one serial killer. So that is a specific immune defense. Some more definitions. You've heard me use the word chronic. It means long-term. Acute means short-term. All right. What's the cutoff? When does a disease go from short-term acute to long-term chronic? And it's different for every department. It's different for every specialty. Some places call it 6 months as a cutoff. Some places call it 1 month as a cutoff. As far as immune system, infectious diseases go, they go acute means mostly days to weeks, and then when it's much longer, like it's been true since the last checkup, then they say it's chronic. We're not going to worry too much about where the cutoff is. I'm not going to test you on it. Remember I said an agent is the thing that must be there for a disease to happen. And this is true for chronic diseases next week, for non-communicable diseases next week. And for agents in communicable diseases that is the microorganisms. A host is you. You are the person, whether you are infected already or not yet infected. This is where the microbe must live in order to reproduce itself. The environment is the world we live in that can either inhibit or make it easier for microbial infections to travel from host to host. So we're talking about something called the chain of infection. The chain, like the links of a chain, right? And what is it about a chain that's especially interesting? The attribute, which is a chain can be very strong. However, it's only as strong as its weakest link. Chains can have links made out of iron or steel or titanium, whatever you want. But if one of those links have a crack in it or manufacturing defect or somebody's sawed through it already, then that link is where the break will happen and the chain will fail. Here's the chain of infection as we know it. The pathogen, now that's a new word, is an agent that caused disease. Wait, I thought an agent is the agent that caused disease. Yeah, because the pathogen, anytime you see the letters gen at the suffix of a word, it means something. It means the thing that's creating the word in front of it. So patho is disease. Patho literally means something bad happening. So a pathogen is a thing that makes something bad happen. You can think of it as a subset of agent, like an agent of disease. And so it could be a matter of culture or tradition why we have both words. Here's the difference. An agent is a thing that must exist for anything to happen, whether a good thing happens or a bad thing happens or a neutral thing happens. Like James Bond is an agent, a secret agent of British Secret Service. And as far as the British government is concerned, when James Bond is successful, a good thing happened. The villain interprets that as a bad thing that happened. So good and bad is a matter of opinion. But an agent is anything that must be exist so that something happens. A pathogen is an agent that must exist so that a bad thing happened. And bad from whose point of view? From you, from the host's point of view. A reservoir is where these microorganisms live and reproduce. It can be a host. The previous host, the host that's already infected, is now growing more generations of the microorganism in them. A portal of exit then is how it goes out of their body. The route of transmission is how it goes from host to host. A portal of entry is how it goes into the next host. And then we're still not done yet. There must be an establishment of infection in the new host. Just because a microorganism like a bacteria virus got into your body, it doesn't guarantee that an infection will now happen. They could fail. And maybe the immune system of the next host is really on the ball, ready for action, and they successfully detect and destroy the microbe. Then no infection happens, even though the exposure happened. Of all of these, which do you think is the weakest link? Well, I already told you it's transmission. Is a list of modes of transmission, how microorganisms go from an infected person to a not yet infected person. Droplet means cough or sneezing, the respiratory droplets. Airborne means it stays in the air for a long time. What's the difference between the two? They sound kind of similar. They both go out the mouth. Droplet is for microbes that must stay in a moist environment in order to survive. So they are riding in the tiny, tiny droplets of respiratory humidity. Once those respiratory droplets, the steam out of your breath, dry out in the outside air, then those microbes are destroyed. They dry out, they disintegrate, they're gone. Airborne are microbes that somehow survive the dehydration process. They exist as some kind of a spore, a dry spore, and they can now float out in the air so light that even the most gentlest breeze can keep them up into the sky until they're finally breathed in by somebody else. And then the moisture inside the next host's respiratory system rehydrates, reactivates the microbe, and they're able to act again, to do their thing. Direct physical is, as it says, one person touches another. And now, usually that means that there is some kind of micro tear, not even a large wound. It could be a wound that's so tiny it can only be seen under a microscope, and that's how the microbe gets into the body. And so sexual transmission is exactly that. Indirect is, it's not through direct transmission, but somebody touches a doorknob and then somebody else touches the same doorknob and then licks their fingers or rubs their eyes. And then now the next person has got it. And another example is doctor's necktie, which is why some hospitals prohibit doctors from wearing long neckties. Imagine that. A doctor goes from patient to patient checking on the round, and after each patient, they wash their hands like they're supposed to. They wear gloves like they're supposed to. Some of them are even conscientious enough to wipe down their stethoscope with alcohol. They're all supposed to do that, even nurses. But they forget to clean their neckties. And so the necktie touches one patient after another and it just spreads the disease throughout the hospital. So some hospitals say, stop that. If you must wear a necktie, wear a bow tie. But otherwise, no more necktie, no more long ties. A buffet spoon, ever think of that? Let's say somebody goes to the bathroom, does not wash their hands, comes out, touches the buffet spoon, and then moves on. And then you come along and touch the buffet spoon, and then you touch your fingers touch the food on your plate to put it in your mouth, and then eventually you got it. I love buffets. I still go to buffets. And what do I do? And well, there's the old method of get sick, grow immunity, and it's not a problem. But more seriously, what I do now is I never touch buffet food with my own fingers. I always use fork, chopstick, spoon, the utensils. Even if it's air quotes finger food, I never touch it with my fingers because I touch the buffet spoons. Since the pandemic lockdown, after the lockdown, now all buffets that I've ever been to have complimentary plastic gloves available next to the tray of plates. You can do that if you want, and nobody will think you're weird anymore for doing that. So those are two strategies. Other indirect modes, fecal oral, which means from their ass to your mouth. And before you say, whoa there, I'm not that kind of a person, like, no, it's not like that. Okay. Somebody has a microorganism, infectious disease in their bowels, and then they go to the bathroom, and then they don't wash their hands, and they come out of the bathroom. And it turns out they are a food preparer at a restaurant. And even the most expensive, fanciest restaurants have this problem because even though they're charging you an arm and a leg at the menu, they're still paying their low-level kitchen staff minimum wage. And so, and the boss is still a jerk, same as any other company, any other business establishment. And so the employees are restless or resistant. And so even though the sign says employees, all staff must wash their hands, some of them don't. Anyway, they come out, prepare your food, and then you eat it, and now you got it. That's fecal oral. Bloodborne, that is usually direct, doesn't have to be. It can be transmitted by infected needle, that's indirect. Sexually transmitted is also counts as bloodborne, so there's some overlap here in definitions. Vector-borne, any animal, any living animal that carries it, like a dirty needle. A dirty needle is vehicle-borne because it's not alive, but a live thing acting like a dirty needle is vector-borne. So, malaria. Malaria is a deadly, fearful disease, but it's transmitted by mosquitoes. Mosquitoes do not cause the disease. The mosquito is not an agent. You can get malaria without a mosquito. If some evil villain carried around malaria-tainted blood in a syringe and stuck people in the subway, then they will get malaria, or they could get malaria, and no mosquito was involved. So a mosquito is not an agent. However, it is a vector. The Black Plague, what was that disease that was causing all the news a short time ago? Hantavirus. Hantavirus is in some of its early phases is transmitted by rat droppings. The rat is not an agent. You don't need rats or rat droppings to get hantavirus. If you spend quality time with somebody who is already infected, then you get it too. But rats sure do help. Rats do a great job of spreading around their droppings, and so they help accelerate the spread of hantavirus if it ever does appear in a community. So rats are not agents, but they are vectors. Vehicle-borne can be the dirty needle, dirty hypodermic needle, can be doctor's necktie, bathroom doorknob, buffet spoon. A carrier is often meant to mean somebody who is infected but does not show the signs. So there is no way a casual observer can tell this person is infected without a close physical exam and blood tests in the hospital. Did you know that 1/3 or even up to 1/2 of all Americans do not wash their hands after going to the hospital? So even though in my previous story, some of you said, "Ew, that's disgusting. Why don't they do that?" Well, I got news for you. You can't assume that the person you're shaking hands with in the office, in a high-rise tower, in a um, posh posh meetup did wash their hands. They can say they did, and there's no way you can prove it. So I would say you should always wash your hands when you come home, no matter who you think you've been with. Examples of fecal oral transmission, you have the E. coli, and that's the example of the restaurant worker not not washing their hands after going to the bathroom. E. coli is also famously spread by restaurants that do not fully cook their meat. So, either by accident or in purpose, the management orders that the meat on the menu is not cooked as long as it's supposed to be in order to save money on fuel costs. Hepatitis A is known to be spread by fecal oral. In the homework assignment, I'm going to ask you, what are the modes of transmission for the following diseases? And hepatitis in general is bloodborne. So those of you who Googled for hepatitis will get bloodborne, and that'll be your answer. But the way I worded it, the question was that what was the most well known or the most common mode of transmission for hepatitis A, and that's fecal oral. So those of you who are listening to my voice right now, congratulations, you are going to get that question right. For those of you who say, I don't need to watch the video, he's boring anyway, and you just go with Google, you don't even bother. I'm not saying you, like there are students who I suspect don't even read the slides. They just Google for all the answers. The Google is going to tell them, AI is going to tell them it's bloodborne, and that they'll put that answer down and they'll be wrong for this reason. Listeria, about every year or every other year, there's a news about a product recall of sliced salad or pre-cut salads, and it's been found to have listeria, food poisoning, and that is also fecal oral, which is that the the farm workers go to the bathroom, don't wash their hands, handle the vegetables, and then somehow the other side of that building comes pre-cut salads in plastic bags. And they're supposed to be washed. They're supposed to wash their hands. The vegetables are supposed to be washed. All that good stuff's supposed to happen. Somehow it doesn't, and an entire product line of salads have to be recalled because it's causing people to have bloody diarrhea. Cholera is an ancient disease, an ancient scourge of mankind. It's also fecal oral. And this is how it works. The people who are infected poop into not sophisticated, crude bath toilets or outhouses, or into holes on the ground or just right on the ground. And then the cholera microorganism follows the liquid trail down and soaks down into the water table. And then somewhere nearby is a well or a river or stream where people get their drinking water. So they scoop up the well water with buckets and then use it in their daily activities. And so that's how cholera is spread. Well, that was in the old days, right? Don't we have modern plumbing that takes our poop far, far away? And don't we have indoor plumbing clean water sources, so that should never happen. Well, some areas of the world, they still use outhouses and wells, and some areas of the world, their plumbing system is not fully well contained. And then some areas of the world get flooded more often than others. When a hurricane or severe rainstorm comes through an area where the plumbing system um, is not peak level, max level, then what happens is the sewage system can overflow with rainwater, and then that contaminated water soaks into the ground and ends up contaminating the water reservoir wherever they get their main water from, and then cholera is reported. Every year, hurricanes rip their way through the Caribbean, and that hits the news. That gets all of our eyeballs. But then a couple of weeks later, reports of cholera from those islands in the Caribbean also start trickling out, but few people pay attention to those except public health officials and health teachers like myself. So let's recap with an example here. So we want a chain of infection of the cold, the common cold that happens to all of us. No big deal, right? So the agent is the cold virus, rhinovirus, coronavirus. No, not COVID-19 coronavirus, but like one of the older family of corona. And then it leaves the reservoir through the throat of an infected person. So somebody is not, they don't even have to be coughing, they can just be exhaling into a room. And so that's the portal of exit out the nose and mouth. And then it's either direct transmission or indirect transmission. I meant to say indirect transmission because it travels through the air. This is droplet. We can even say droplet transmission. It travels through the air in respiratory droplets, and then you breathe it in. And then it enters the next host through portal of entry, which is the mouth. And then it doesn't always establish a new infection, because if somebody with the sniffles comes into class and then by the end of class time, like 2 hours later, maybe like one or two other people start sniffling too. And then maybe by the end of the day, like 3 or 4 more people start sniffling too, but not everybody. Why? What happened? Well, some of them were more resistant to the virus, their immune system is stronger, or the air currents just didn't go that way. Anyway, the easiest way to break this chain is in transmission. Don't let respiratory droplets out of the mouth of somebody who has a cold. How do you do that? With a mask. What about the people who are not yet infected? The best thing for all people to do is wash their hands. Warm water and soap for about 20 seconds. And when should you wash your hands? After coming home, before cooking a meal, and before eating. When trying to predict how serious a infectious disease epidemic is in a population, then healthcare providers as well as public health officials worry about these things: infectivity, pathogenicity, virulence. So as the text says, infectivity is how quickly or how able an infection can, a microbe organism can enter a body to evade body's defenses. Once it's in, pathogenicity is the ability to cause an infection, cause a disease in the host. Virulence is how bad of a disease it's going to be. So pathogenicity and virulence sounds like the same thing, but pathogenicity is kind of like a it did or it didn't. So it's a probability of it will or it won't. Something like if something is like 80% likely to cause a disease, or 10% likely it can cause a disease, it doesn't actually speak to how bad the disease is going to get once it started. Virulence is what it addresses. Like once you do get sick, how bad is it going to be? For an example, the common cold, as I used before, common cold is a very high infectivity. Somebody sits in a room with you for several hours and you haven't got the cold yet that season, then there is a pretty good chance you're going to start having an itchy throat by the end of the day. But so the pathogenicity is also kind of high because, yeah, once you're exposed, it's pretty good chance you'll get it. But it's not going to be that bad of a disease, right? We all get colds once in a while. I get a cold every winter, sometimes in the big end of spring too. And so it's not, I mean, so what? I don't even stop going to work. I show up anyway. I put a mask on my face. Unless everybody is in the room is coughing too, then I don't even bother wearing the mask now that I see that everybody else has got it too. So virulence is not so bad. Now, what about a flip side? Did you know that HIV/AIDS has a low pathogenicity? Even if somebody has been exposed to the HIV virus, it doesn't guarantee they'll have HIV/AIDS in them. The term is called seropositive, meaning it's showing up in their blood. Then why is everybody so terrified of AIDS? Because it's life changing, literally life ending. People who are HIV positive are now completely dependent on antiretroviral drugs to suppress the symptoms down so that they can live. Once they have access to these drugs and take them regularly, then they can have a full, rewarding life, and nobody else could even tell that they are HIV positive. They can even have sexual relations, start and grow a family, as long as they're on these drugs. But if they're not, if they lose access to the drugs, such as loss of health insurance or stuck on a deserted island, then that's it. In order to interrupt the chain of infection at the mode of transmission, what we're talking about is preventing the infection from happening. We're not, let me scroll back here. This is slide 22. We're not talking about waiting until somebody's already sick and then treating them with antibiotics. Antibiotics are expensive. They're a little hard to keep up with. So it's the next best thing, but really the best thing to deal with an infectious disease is stop the general public from getting infected in the first place. So how do you stop the general public from getting infected in the first place? Well, for the individual, the best thing to do is to have a strong immune system. How do you strengthen your immune system? Well, your immune system is incredibly energy intensive. And so you need to give it lots of energy and, of course, the raw materials to do its job. So since the immune system is energy intensive, then you want to conserve your own energy. So get enough rest. If you get weaker, and then your immune system doesn't work so well and you are more vulnerable to infectious disease. Avoid stress. Yeah, I know that's hard. It's easy to say, hard to do, but that doesn't change the fact that it's important. Stress weakens the immune system because of energy. Stress drains the body of energy, and then the immune system then is impaired. This is why infectious diseases, especially respiratory infections, rise in final exam season as students all over the world are stressed out. All that procrastination from early in the semester, they've been kicking the can down the road. And what did they do? Eventually, they reached the end of the road where they found a lot of cans. Then now they have to deal with every one of them, and the stress levels go high, and so does infection rates. Eat right, not just eat. It's not just don't just subsist on coffee and potato chips, but eat right so that the raw materials, the vitamins and minerals, the fiber, all of the protein in the correct amounts is there for your immune system to draw on for raw materials, to build more troops, to construct the ammunition and the trucks. And these are all war analogies, but that's what it is. There's a war going on in your body. Stay hydrated so that the roads that your troops need to travel around are in good condition. Your blood vessels are the roads that your troops travel on. So staying hydrated is how you take good care of your blood vessels. Get vaccinated. And for those of you who are anti-vax, please wait till the end of this lecture so I can explain to you why vaccination is actually a good thing. And be well, be healthy. And in the World Health Organization said that the true definition of health is wellness, both physically, mentally, and socially. Reducing risk factors then staying healthy is one way to reduce risk factors. There's no way to completely remove the possibility of getting infected. Some people can do everything right and be in exactly the best situation, but they get sick anyway. It doesn't mean the doctors are wrong. It doesn't mean the big pharma is lying to you. It just means somebody threw bad dice and the random events of the world conspired against this individual despite their efforts. It doesn't mean it's not worth trying. It just means that it was just not a lucky day. So there are other risk factors to consider. Some of them are non-modifiable, like heredity, like where you got your DNA from, as well as your epigenetics. You can't change that. You can legally change who your parents are, but you can't change who your biological parents were. You cannot change how old you are, not now at least. Every year there's news articles about billionaires funding yet another project to try to solve aging, but so far it doesn't seem like anybody's fixed it. How do I know? Because the top 1% are still getting older, right? Once you see this top 1% getting suspiciously not old, then you can start asking questions. So you can't change how old you are, but you can change what aging does to your body. Comorbidities means other medical issues that can interfere with energy and nutrition. So comorbidities, and there are opportunistic infections, which is sort of opportunistic, meaning when your immune system is weakened, other infectious diseases that were kept at arm's length are now able to get closer or even invade the body. And then their invading the body distracts your immune system. So part of your army has to go there to deal with that. And then there's less of your immune system to deal with the main infection that's scaring everybody. And so it makes the person more vulnerable to another infection. Environmental conditions are modifiable because even if you feel like you're stuck in some place of the world, that's only true until you win the lottery. And now you're not stuck there, right? So in medicine, that's called modifiable. It depends on it depends on situations that can change versus situations that cannot change. And then there's the organism's own virulence and resistance to drugs. Prevention is the best way to deal with an infection. Don't get sick in the first place. But then there's three kinds of prevention: primary, secondary, tertiary. Primary, secondary, tertiary. These terms are used a lot by a lot of places to mean a lot of different things. In this context, primary means the first line, secondary means the second line, tertiary means the third line. So primary prevention is don't get sick in the first place. Wash your hands, personal hygiene in general, all of this other stuff. You can pause and read it. And so, yeah, here is more. Now, what about a public health point of view? These are what individuals can do. And as a public health official, you can encourage individuals to do it. But you can also act on the community itself, such as chlorinating the water supply. Now, not chlorine levels like in the swimming pool. That's just dangerous. But uh, a little bit to stop things from growing in the community water supply. Then that's good, right? Because it reduces the chance that people will get sick just from drinking the water. In general, with medications or any treatments, a little bit is good, even, and then a lot is bad. Whatever the city is adding to the water supply, you can, no matter what it is, you can go to your favorite browser or your favorite social media channel and look, and you can find all kinds of people saying that ingredient is killing people, it's making people infertile, it's government conspiracy to control people's minds. I don't know about the mind control thing, but any chemical, any artificially synthetically introduced chemical in large enough amounts becomes a poison. But in small enough amounts, it is beneficial. And then if it's smaller than that, then it has no effect at all. So chlorine and fluoride, which reduces tooth decay, added to the water supply is a good thing, but only in small, the right amounts. Restaurant inspections, that's not what individuals do, that's what communities do. Immunization programs, so that more people end up immune to the disease, the infection, and then it spreads less. So that's preventing. Vector control, like mosquito control programs. I spent 2 years in an island that had no mosquito control, and it showed. And I still have PTSD from mosquitoes to this day. Waste disposal, right? For the to prevent fecal oral transmission, but also waste disposal as in the garbage disposal, so that rats don't accumulate and then spread hantavirus, for example. Um, Now that I've mentioned it, hantavirus has been in the United States for a long time. It spreads by rats. It's usually, there's a spike of hantavirus at different parts of the country from time to time, especially after a big rain, because big rains cause vegetation blooms, and then the rats eat the vegetables, extra vegetables, so they multiply. Then they leave more rat droppings around, and then a human wanders by and gets hantavirus. So it's been a thing. It's not like a suddenly new. The reason why it's on the news suddenly, because it infected that cruise ship, and now suddenly rich Americans who didn't spend much time in the wilderness are now affected. And that's causing, and this also, they're stuck on that ship. So that's kind of dramatic. And also, the ship is going from port to port, potentially spreading it around. Sounds like the beginning of a zombie movie. So that's capturing people's imagination. But the disease itself is not new. Secondary prevention is after the primary prevention has failed. Now the person does have the disease. Then what can you do about it? Well, if they already have the disease, is it too late to prevent it? It's too late to prevent them having the disease, but it's not too late to prevent it getting worse. And that's what secondary prevention is. Secondary prevention is preventing the effects of the disease from getting worse, progressing. And with infectious disease, of course, that includes not preventing this person from spreading it to other people, which could include like quarantine, isolation, etc. So once the person has the disease, what is a part of secondary prevention? Well, diagnosis. The person should recognize it in themselves, take themselves to a clinic, report it to their doctor, primary care physician, etc. They can try to treat at home, but then after the home remedies don't work, after a while, then again they report themselves to the hospital. The hospitals then can I try to identify what is the agent, and then choose a medication that's specifically targeted to that agent. Community-wise, then it's surveillance, tracking what's happening, how many people reported to which clinic, complaining of what. So they're tracking amounts and severities and rates of spread across a population, because then the public health officials can send teams in to try to slow down the spread of disease across population. Disinfection also. So after it's not, of course, some minimal hygiene disinfection is a good idea, but if there is a spike in cases of infection in an area, then extra levels of disinfection in that area can be ordered. That's the community level. Tertiary level is after you're treating the disease, what else could happen? Well, what about side effects of the treatments? Everything in medicine has a side effect, has multiple side effects. There's no such thing as a medical treatment that does not have side effects. You give somebody a glass of water, they can drown. Okay, more seriously, you give somebody a glass of water, they can choke on it. So you want to be careful that before you hand somebody a glass of water, that they be able to maintain their own airway. They have the mental capacity to handle a glass of water and drink in safety. You don't want somebody to drink too much water, because, again, a little bit is good doesn't mean too much is good. Too much can be bad. Somebody drinks way too much water, they can dilute their blood so much that it causes some very serious effects. Getting carried in an ambulance can have a side effect. They could get into a car accident. So, and then of course, every serious medication has its own side effects. People who buy medications over the counter at the drugstore really should be reading the label, the warning in the back. So treating these potential side effects is part of tertiary. What are they preventing? Preventing the side effects of treatment from making things worse. Somebody has a broken leg. Well, I think it's in this. I think it's in the next slide. Oh, so communities. In an epidemic, some people end up dying. It's just, some people were that sick. They were so sick that they can't tolerate yet one more thing. And then this one more thing comes along, this epidemic. So it causes loss of life. What do you do? What happens? Then effective and appropriate removal of the deceased is part of tertiary. As public health officials, now they have access to initial sets of data, and then applying the information they've obtained so far to try to reduce the spread of disease in the population, again, also overlaps into tertiary. This chart is an example of the difference between primary, secondary, and tertiary. HIV, okay, how do you not get HIV/AIDS in the first place? Wear a condom, practice safe sex, avoid IV drug abuse. I think all of you are aware of that. But now, secondary, what if they have HIV? What, they got exposed and they turned seropositive. Now they are HIV positive. What are they supposed to do? Of course, they need to keep up with the antiretrovirals, to their medications, do what they got to do to maintain their access to it, keep up their insurance plans, be able to continue to be able to afford these drugs, join in on social, community programs that makes it easier to access these drugs. What are the side effects of these medications? So these patients, they have to watch out for the side effects and keep track of it. Another thing they can do is maintain their own health. These drugs have given them a second lease on life, and they shouldn't squander it. They should take care of themselves. They should avoid the behaviors that got them into this situation in the first place. They need to spread the word for safe sex and to avoid IV drug abuse. Don't share dirty needles. Don't share any needles. COVID. So we were just here or any influenza-ish. That's my term. I just made up that word. It's like something like an influenza type virus. So how do you not get a respiratory infection? Wash your hands. If the the community orders it, wear masks, social distancing, get vaccinated. Let me move this here. Okay. Um, and now, what if you did get COVID-19? Then you got the actual antiviral, and then some people, not everybody, but some people needed a catabolic steroid. This lecture is not about specific diseases, so if I did, it would take all day, if not longer, to finish this lecture. But anyway, steroids are a part of severe infection, not mild COVID infection, but severe COVID infection. And then each one of these cause side effects. So sometimes the doctor may order more medication to handle the side effects. During the lockdown, the purpose of making everybody wear a mask was so that if one of them was infected, they will not spread it to others. Let me say that again in a different way. The purpose of the mask during the lockdown is not to protect the individual from getting the virus. The purpose of the mask during the lockdown was so that if somebody was infected and got into a public space, they don't spread it to others. There, that should take care of half of the conspiracy theories and anti-mask social media comments, because they were saying, those social media comments were saying, see, the size of the virus is smaller than the holes in the mask, therefore the mask is useless. So the problem with those statements is that the COVID-19 was a droplet transmission. The holes in the mask didn't have to be as small as the virus. The holes in the mask had to be smaller than the size of the respiratory droplet, because once the virus was caught outside of a humid environment, it dried out and it was destroyed. It did not survive dehydrated. So as long as the mask stopped the respiratory droplet, that's minimized or reduced the chance of spreading. Remember during the lockdown that the public was asked to wear a mask, any mask. Why any mask? Because the public health officials were worried that if they tried to give too much detail, then it would confuse the public, and then it would make compliance even worse. So as long as something held in the respiratory droplets and prevented the person from breathing it out, then it was good enough. Good enough for general public. And after all, one key phrase we should try to remember anytime in healthcare is, don't let the perfect be the enemy of the good. If something is good enough or better than nothing, then it's better to do that than wait for something perfect. Sometimes the perfect solution is impossible or impractical, but something that is good enough is better than nothing. So a bandana, can you see my mouse? Yeah, the bandana here, or any t-shirt or anything else that people who were very creative at the time invented, was good enough. It kept in more respiratory droplets, preventing them from spreading it out. And that's good enough for like grocery stores, libraries, office spaces, subways, standing in line. That was good enough. At least it was better than nothing. It was definitely better than not wearing any mask at all. See the graphic difference between the distance that breath can extend out like that. Okay, now inside of a classroom, uh, especially in the healthcare related classrooms that I was teaching, we did not allow just any mask. We required people to wear at least a surgical mask, triple layer surgical level mask. That's what people in the hospitals all wore, or in those days, those who could, because supplies of masks were really strained. And you see how, if you look really closely, that some respiratory drops did escape out of the mask, but but at least it was better than a non-professional mask. The best kind of, by the way, these surgical masks only work if the nose is covered. How many times have you seen somebody wearing a mask but their nose was not covered? So what happens when they exhaled? Then the respiratory droplets zoomed out as bad as if they wore no mask at all. People who wear the mask but does not cover their nose, it is as effective as wearing no mask at all. At the beginning of the lockdown, I tried to tell that to like store clerks who were exposing their nose. And then they started giving me excuses like, yeah, but blah, blah, blah. So some of them genuinely believe that it's not a big deal. Or, I mean, that I was, um, some of them genuinely believed that it didn't make a difference. Some of them knew inside that it was making the mask useless, but they just didn't care. Their boss was forcing them to wear the mask. They don't believe in the mask, but they're doing it because otherwise they would get fired. So whenever the boss was not working, they flipped down the mask, exposed their nose so they could be more comfortable. And for sure, wearing a mask properly will be not comfortable. Because remember, what was the purpose of the mask during the lockdown? Was to keep the respiratory droplets on the inside. What does that make the inside feel like? Muggy, hot, smelly. You wear it for long enough, then fungal spores start growing. It starts getting disgusting in there. So no wonder people didn't like to wear the mask. But this is how we minimize the spread of infectious disease. The people who are the most fly, the most swag, for people who can really show off how well connected they are, wore a N95 or KN95. KN95 is the Korean version. 95 stands for 95% of known particles. And that not only blocked respiratory droplets, but it also blocked the virus itself. The N95 had holes that were small enough to block the virus itself. So N95 not only stopped people from spreading their virus around, but it also helps stop people from inhaling other people's viruses. These were near impossible to get during the lockdown. The few that you got probably were counterfeit in those days. Nowadays, you buy an N95, it's probably legit. So for those of you who are like genuinely worried about the next pandemic, maybe you want to stock up, like have a box of these in the storage room, just in case. I'm not saying one is coming, but life finds a way. We cannot predict the future. So I can't say it's not going to happen. I also can't say it will happen. One thing that is absolutely no good for classroom is anything with anything with an outflow valve. You can tell what these are because it looks like an ordinary mask, but it's got a plastic something in the front. And the idea is that it'll gather up all of the exhaled breath and send it out in a directed jet. This is even worse than no mask at all in terms of the purpose of this mask. Remember what was the purpose of this mask? So that people who were infected don't spread their virus around. So if this person was infected, they just turned this mask into a sniper rifle and just made sure that any point they were looking at would get their virus sent out. If you say, oh, then I know I'm not infected, so I don't have to wear a mask. Maybe you know that, but how does a stranger know that? Or what if a stranger said, don't worry, I'm not infected, so I don't have to wear a mask? How will you feel about that? as a stranger tries to walk in on your personal space, tries to interact with your loved ones. Surveillance is how public health officials keep track of what's going on. How are they supposed to react to something if they don't know that something is happening, right? So there is passive and active surveillance. Passive is the public health officials sit back and wait for routine reports to come in, and they just put it into the spreadsheet and put it into the graph and see if there are any unexpected bumps or spikes in it. It's great for when they don't expect anything unusual to happen. It is cost effective, but the problem is it's slow to respond if there is an emergency. Active surveillance is when they do realize something is happening, something special, something urgent, and then they take an active role. So they expend resources, they use up some of their budget, they send teams to figure out what's going on. Zoonotic surveillance, the zoo in the word, means that they're tracking animals. So migration of animals, transport of animals, and of course, the spread of disease in animal populations may be reported by wildlife officials or agriculture officials. And so public health needs to be told about any unexpected events in this way. When another way to save money so that they can extend their budget, their limited budget and staff, is to have sentinel sites. So instead of watching the entire population, watching the entire countryside, instead they select certain areas that are like representative of a region. The idea being that if there is something going on in one part of the country, then eventually the it'll reach one of these sentinel sites, and there they have a monitor, either a human being or something else, keeping an eye on incoming data. And then when it's detected, it flags, sends an alert to headquarters, and then the headquarters can send more staff, more resources to monitor the rest of the region. Community-based surveillance is when there are some diseases where it's so mild or the patients are extra reluctant to tell their healthcare professionals, then how are they supposed to know that something is going on, right? So then they rely on other people other than healthcare professionals to do the monitoring, such as teachers, school health professionals. They notice that one of the kids is looking especially sick, not just one day, but like several days in a row. Alternative care facilities, and that could be anything. Could be alternative medicine, complementary medicine. It can be non-typical, non-traditional healthcare facilities. Other places where if somebody was sick but didn't want to tell anybody, or would rather not tell anybody, then but it's noticeable, then somebody is there to raise the flag. Individual homes also, people can be asked to, maybe the public alert is sent out to say, if you have these symptoms, please call a healthcare provider. So that way they can catch it. This is also great for those diseases that are near elimination, like diseases that have almost been wiped out of the country because public health efforts have been so good. Well, we don't want this disease to start growing again later, so we would rather hunt the last ones down and then find the last few people who still have the disease, bring them in, treat them, cure them, and then now we can effectively, well, we'll never truly eradicate the disease because some will always slip through the net, but at least we've reduced the chance that this disease will rapidly reappear in the future. Contact tracing, that's something you've been part of, right, during the lockdown, where it's kind of like a sentinel site, is that if one person is identified with an especially virulent disease, then staff are now deployed to find out who else this person has been in contact with their friends and family, their relationships, classmates, co-workers, all of that, all of those people. And then each one of those people are contacted and asked, who have you been hanging out with? And then please come in to be evaluated. Now, not all of them will be infected. Remember the infectivity, pathogenicity, and also that establishment of in a new host link of the chain, right? But if one of them did get infected by this person, then at least we have a chance of finding them. People who have taken vaccines, some of them do get side effects because that's how real life works. And vaccines are not 100% effective and they're not 100% safe, but they've helped so many people that it's worth the risk. The benefits outweigh the risk. But we don't abandon, we as in the greater medical community, do not abandon those who have side effects. They are taken care of course. That's the tertiary prevention of healthcare. And so, how do we find out who had any side effects and what they are? Well, then there are different tracking websites, different systems. When designing a surveillance system, the public health official needs to answer these following questions and deal with the following issues, right? What exactly are they looking for? You can't just say, I'm looking for COVID-19 because the COVID-19 virus mutates, right? So the virus we knew about 5 years ago may not be the virus we're dealing with later. And so there are ways to specify the attributes of the disease we're looking for. But that raises the possibility of false positives and false negatives. Remember the basic science lecture on this. And again, why can't they develop a test that's 100% accurate? Because this isn't fantasy land. This is the real world, and the test will never be perfectly accurate. So which way do you want it to go? Do you want to have a little more false positives and minimize the false negatives, or do you want to have minimize the false positives, but thereby resulting in increased false negatives? Um, Anytime a test is designed, it has to be aware of the realities that whoever's administering this test does not have infinite money, does not have infinite time or personnel. So you have to respect their limits. Remember, don't let the perfect be the enemy of the good. Are there new technologies that will make either assist or hinder the surveillance as it is designed? Because social media can be used to make it easier to track a disease across a population, but then social media can also be used to make it harder. There can be conspiracy theorists, or medical skeptics out there intentionally muddying, fogging the landscape, or there can be people who are misunderstanding the assignment and are misreporting, throwing all kinds of false positives and false negatives into the internet space. So somebody needs to really know what they're doing when they use new technologies. Getting compliance from the public. So yeah, social media misinformation is real, and it's going to be here to stay. So just like there will be segments of percentage of the population who never believed what a doctor told them, now there are segments of the internet who don't believe what public health officials say. That doesn't mean like give up and go home. It means address these concerns. Disseminating surveillance data. So you have this data. Now, what do you do with it? Right? Of course, you use it to adjust your strategies, your tactics, but it's good to share this information with other partners, other healthcare institutes, other agencies, other governments, other parts of the world, so you can share each other's information and get a better picture. Remember that parable of the elephant and the blind man? So this is true here. Finally, choosing where to address resources can come down to some of these criteria. There's more, but here's our start, right? Once the information starts coming in and the graphs start getting plotted, then try to find out how many people were affected, how many ended up dying from it, and then even the ones who have not yet died, how many years of potential life lost. Remember DALY, DALY, and HALE in the second half of Basic Sciences lecture. No, sorry, that's the epidemiology lecture. So these apply here. What are the economic costs? It's not just the medical costs that have to be considered. What does getting that many people sick do to the economy, as they can't work, they can't pay taxes, they can't have the money to pay their bills? What does that do to the city infrastructure? And also, the orders to lock down the city or lock down the country because a especially virulent disease is spreading through the nation. What does that do to the economy? That has to be taken into consideration too. For the people who are really, really sick, then before they even the ones who really are sick, then you don't want them to contribute to the spread of an infectious disease. So isolation. These are people who are infected, and you want them to not go out there and spread it around. The word quarantine is a little bit less severe. So people who might be infected, which means they could be later, they found out to be later, and it would be a real shame if you just said, nah, don't worry about it. And then they go out and spread it around. And then you say, oh, by the way, you did have it, so please come in, right? So before they have a chance to spread it around, tell them to shelter in place, or act like, try to be isolated. They don't have to try as hard as isolation, but make some effort in it. How long should they do it? Until it's confirmed that they don't have it. And that's called staying inside the incubation period, which we will cover in a few slides below. For those of you who speak Spanish or Italian, this will look familiar because in Latin, quaranta means 40 days. And it goes to the story of back during the bubonic plague in Europe, the Black Death that killed 1/3 of all white people on Earth. Yes, it was that bad. It killed 1/3 of all white people on Earth at the time. It terrified Europe to no end. And ships would appear at port from a distant land, and the village, the city, was terrified that the ship was bringing the Black Death. And the sailors would keep saying, no, no, we're fine, we're not infected, but nobody believed them. And finally they said, what do we have to do to show you, to prove to you that we're not infected? So the village leaders, the city leaders, where did they turn to in those days? The Bible. Because if it was good enough for Jesus, then it's good enough for them. And so Jesus spent 40 days in the wilderness to through a series of tests and survived them. So they say, hey, let's do that. So you stay on the boat for 40 days. And if you still have no symptoms after 40 days, then okay, we'll let you come into port. So that's where quarantine came from. During the lockdown, shelter in place, stay at home was for everybody to, again, to minimize the spread of this very virulent and deadly disease. Halfway done with this lecture. Congratulations to those of you who have made it this far. I hope most of you have been listening at faster than 1x playback speed. And also, for those of you who are convinced anti-vaxxers, thank you for staying with us all the way up to this point, and I'll explain to you why vaccination does more help than harm. So immunity, vaccinations help immunity. Now, who is vulnerable to diseases? Well, people whose immune system is weakened. who would have weakened immune systems, the very young, the very old, and the very sick. And in the very sick, any disease that robs the body's resources and energies will weaken the immune system, make them vulnerable to diseases. Vitamin A deficiency weakens the immune system. No, vitamin A overdose does not strengthen the immune system. Vitamin A, adequate vitamin A, brings the immune system up to where it's supposed to be, but it does not supercharge it. Some diseases actually target the immune system, such as HIV/AIDS. So these people are immunocompromised. That means they are wide open to opportunistic infections unless they take their antiretroviral drugs as needed. Immune suppression. Some people with cancer will take drugs that suppress the immune system. Why? Well, we'll talk about that next week in the chronic disease lecture. People who take a lot of steroids also suppress the immune system. Now, I mainly mean catabolic steroids like prednisone, hydrocortisone, dexamethasone, that kind of thing, not testosterone or estrogen. Those are anabolic steroids. I'm sorry, not estrogen, but testosterone is an anabolic steroid. But some diseases require the patient to take steroids, and then that unfortunately suppresses the immune system. Why is that a thing? I'll talk about it next week in chronic diseases. Immune impairments such as excess fatigue, stress. Now the person is more vulnerable, such as during final exams. Poor sleep, such as during final exams. So if you don't get your regular needed hours of sleep, on average it's 7 hours, but that's on the average. Your mileage may vary. You may be at a different place in the bell curve. Some people don't need that many. Some people need more. But whatever it is that you specifically need, if you don't get that much, then your immune system is weakened. Poor nutrition, so not just vitamin A deficiency, but other vitamin deficiencies, mineral deficiencies, not enough protein, eating too much junk food, bad nutrition. I didn't say insufficient nutrition. I said poor nutrition. So eating poorly, eating too much junk food can weaken your immune system. Poor hygiene. Why is this right? Did I spell it right? Let me just quickly double check that. Is that? Be right back. Yeah, I spelled it right. Why is it complaining? Back to here. I'll just tell them it's correct. Okay. Anyone who regularly, so those are the people who need a vaccine. All these people. Now, anybody who interacts with the people above. So any young person who do not apply, like any young healthy person, maybe they decide, nah, I don't need a vaccine because I'm not at risk. Like I said, you could do everything right, but get sick anyway. So there's nothing is guaranteed in medicine. Nothing is 100% certain in medicine. But if you are a young person who interacts regularly with somebody who is very young, very old, or very sick, then maybe the last thing you want to do is to bring an infectious disease to them, right? Maybe you don't care what happens to your body, but shouldn't you care what happens to this person you're visiting on a regular basis? So then you should get immunized, such as healthcare workers and the loved ones of the people who are very young, very old, and very sick. Immunity is two major group breakdowns. There's humoral immunity and cell-mediated immunity. I'm not going to test you on these definitions. You just know that in humoral immunity, humor from the blood, I know that's spelled correctly, we're talking mainly about antibodies. Antibodies are specifically designed to attack a specific molecule and nothing else. The antibody for rhinovirus can pass right by a coronavirus or a COVID virus and not notice, not care. The antibody is only for the rhinovirus, and that's it. That's how specific they are. But wouldn't you want somebody to react to this random COVID virus that just happens to find its way into the blood? Sure. Well, that's what cell-mediated immunity is. And these are like white blood cells is the most famous example. White blood cells don't care who you are. They only want to see some ID. They want to see identification papers. They want to see papers, please. And every cell, every surface in our body shows the self protein. It's just part of who we are. Every cell, every citizen in our body has proper identification. And if the white blood cell comes along and says, show me your papers, and so one of our cells say, here you are, and the white blood cell says, oh, thank you very much, sorry to interrupt you, have a nice day, and moves on. That's how cell-mediated immunity works. So in general, this is how vaccines work. They expose a person to the parts of a germ in a safe manner, under controlled situation, in a clinic or a drugstore, but administered by a nurse. So it's a controlled manner, and then they don't let you go home. They make you stay for like 15 minutes so you can be monitored for a possible allergic reaction. Now that these parts, not the fully constructed live virus or bacteria, these parts are now in the body, the immune system comes along and says, stop, let me see your papers. And then if no papers are, since these parts don't have the self protein, then the immune system attacks it and then takes some of those parts and starts making antibodies. Not only are antibodies made, but memory cells are also created. Memory cells also create antibodies, but they also create memory cells. And memory cells hang around. Antibodies, since they are just a molecule, it's not a living organism. Antibodies are just a Y-shaped complex molecule. They will eventually degrade and wear away. But memory cells hang around. And so the next time the person is exposed, these old memory cells are like reactivated and they start making antibodies again. So that delay, the first time, delay from exposure to antibody creation is not there at the next time, because the memory cell factories are already pre-existing. They are just reactivated and they start churning out the antibodies to that one specific molecule. And so the antibody response is even greater. This is why some vaccines are given in stages with booster shots, because some microbes work that way. It's why? Well, the answer is very complicated, and it takes an entire textbook or two to explain it. But so today we'll just say that some vaccines are good for life, some vaccines are short term, and it's just the way life works. Life is complicated that way. So the real infection finally does appear, like they finally get exposed to the real thing. But now that there are these antibodies for that surface protein that already been created, the immune response is so overwhelming that these viruses don't have a chance to take root and build a colony. For your convenience, I was inspired to make this drawing. So everything I just said is now illustrated a bit. What your body does. Can you see my mouse? What your body does. So a live virus enters the body and your immune system says, stop, papers please. And then the live virus doesn't have the self protein, so it's attacked. And then the pieces are brought over to this nerd, the nerd of your immune system, who then orders construction of memory cells that activate and it's given this molecule from the invader, and what antibodies, these Y-shaped antibodies, are given this code and said, from now on, you exist to hunt for this molecule. If you ever find this molecule, send out an alert. That's your job. And the rest of the immune system will come running when it hears an alert. Great. And then time passes on, these antibodies wear away. They're still there, but their concentration, their amounts start to degrade over time until one day another exposure happens. And then this nerd comes over, shares the matches the molecule with the pre-existing memory cell, and the memory cell says, I remember, those were the days when I used to make antibodies against that molecule. And the messenger says, no, it's today. It's today. We need you again. Go back online. So the memory cell starts churning out more antibodies. But remember, this time, these factories are pre-existing. So now they don't need a build-up time like in the beginning, and so they are able to respond faster. Meanwhile, the signal is sent to create more memory cell factories. So the antibody response is even greater. And for every new exposure, there are more memory cells, more antibodies, and the immune system is even better prepared for any subsequent exposure. So what do vaccines do back here? What do vaccines do? Instead of a live virus, a fully formed, fully functional live virus, the part of it, it's already chopped up in the lab and then isolated. The surface proteins are isolated and injected in. Depending on the vaccine, some of them would inject a living but weakened virus. So that is possibility, a thing. But now it depends on the vaccine. Not all vaccines are like that. Most vaccines inject a subunit. It's called a subunit, a fragment of the virus, so it can never reassemble itself. Anyway, the immune system doesn't care whether it's a whole thing or a part of a thing. It just knows that this molecule does not have proper identification. So it's attacked. Some of it is brought over to the messenger, and the messenger comes over and says, this does not belong here. Start making antibodies. Start making memory cells, and the memory cells start making antibodies. And then this process continues. I hope this illustration was helpful to you. If you have heard my voice, if you've made it this far in the video, and if you have any thoughts about this drawing, please go to the comment section, the discussion forum, and let me know. Was it a good drawing? Did it help? I'm sorry. Of course, you're going to say it's a good drawing. It's a public statement. I mean, but tell me if there's any way I can improve this drawing. How about that? Please tell me in the discussion forums under miscellaneous if there's any way I can improve this drawing. A vaccine is a artificially acquired immunity. See how this chart goes? Immunity is either artificially acquired or naturally acquired. It's either active or passive. So active artificially acquired means that the patient gets an injection of the agent. Antigen, I should say antigen, not the agent, antigen, that triggers their increase of memory cells. So that's the vaccination. Artificially acquired passive immunity. Passive means the patient does not make antibodies. So instead of injecting the antigen, the doctors inject the antibodies. So the patient doesn't make it, they just get it. Then that's passive. They don't make it, they just receive the benefits of somebody else's labor. Okay, these are all artificial. What's naturally acquired? Well, if the old-fashioned way, patient gets infected by the real germ, the real thing, And so some may say I'd rather get infected by the real thing than by a vaccine, because vaccines are government mind control poisons, but at least the real germ is 100% natural. The real germ kills people. I mean, that's why we have the vaccine program, to save patients and the public from the known horrors of getting the real disease in the first place. Now, and then, but vaccines cause harm too. Okay, so now we have to compare the risks of harm from a vaccine versus the risks of harm from a real germ. And we'll address that. What's naturally acquired? Passive immunity. Mom's going away present. A child is born without their own antibodies. They didn't make it because they haven't been exposed to the foreign antigens that would trigger antibody production. That's kind of why babies put things in their mouths, so that they start building up a library of bad things, but in a controlled environment. Anyway, to not let the baby be completely vulnerable to bad germs out there, the baby's blood is full of mom's antibodies, so that it's like a going away present, and that should last long enough until the baby can start making their own antibodies. A way to make sure that the baby does make their own antibodies is that about 6 months later, the baby starts getting shots, vaccines. So they are artificially acquired. Would you rather wait for the baby to get the polio virus, hoping that the baby builds enough poliovirus antibodies to avoid the disease? Or would you rather it get the polio vaccine and then not be at risk of getting actual polio? Go look up polio, your favorite search engine. Just look up polio. Look up the images of people who are suffering from polio. Do you want to risk your baby getting that disease, or would you go with the polio vaccine? The flu shot, yes, that one, the one everybody's told to get every winter. The flu shot is only 50% effective. Speaking of benefits versus risks. So wait a minute. So I'm exposing myself to government mind control, infertility drugs at the risk, and then all I get for my troubles is only half effective. Like it'll only protect me half the time. Yeah. On average, sometimes it's more effective, sometimes it's less. What's going on? If a vaccine is supposed to immunize you forever, why do we have to take one every year? The thing is that the common flu is not just one virus. It's like a whole family of viruses, and every one of them mutates real fast. So a vaccine built against last year's flu viruses, the most common viruses from last year, are ineffective this year. They have to create brand new vaccines against what's expected to be the common flu viruses for next year. How do they know which ones are going to be more common next year? They watch the southern hemisphere. You know that, like Australia, their winter is our summer, and our summer is their winter, and our winter is their summer, right? So they watch the countries south of the equator when they're having their winters, see which flu viruses are more common there, and they assume that through air travel that people will spread it around all over the globe, and by the time we have our winters, those are the viruses that will show up at JFK Airport and then be in a subway seat next to you that evening. So they try to make vaccines that block those viruses. Sometimes they get it right, sometimes they get it wrong. At the individual level, you may ask, if it's only half effective, why should I expose myself to autism, as the conspiracy goes? Maybe at an individual level, it doesn't, for people who don't know math, it doesn't seem to make sense. But then the question comes up, why do you get car insurance, automobile insurance, when the risks of you getting into a car accident are very low? Why bother? Right? But many people say, exactly. That's why I wish I didn't have to buy car insurance, because I'm a very good driver and I will never get into an accident. So it's a total waste of money. From the individual level, you might be able to argue that. But from the public health model, especially from law enforcement model, at the city level, it's a good idea to force all motor vehicle owners to buy car insurance, because the chance of an individual getting into an accident might be very low, but the chance that somebody will get into an accident this morning, today, is 100%. There will always be somebody getting into an accident today. So by forcing everybody to have car insurance, then whoever does get into an accident will have it. And now whoever is totally innocent will be protected. Whoever's at fault can be fined and they can pay the fine, all because of enforced car insurance. So from a public health point of view, they have to be aware that they have to keep in mind that before the pandemic, influenza killed about 50,000 people every year. The ordinary flu killed about 50,000 people every year. Let me move this slide up because it somehow belongs here. Right. That's with vaccine programs. If there was no vaccine program, if public health officials said, it's only 50% effective year after year, you know what, let's stop trying. And we're getting all this kickback from social media influencers and making people hate us. You know what, this is a thankless job. Let's stop vaccinating against the flu. Then what's going to happen is this could double. Deaths across the nation per year could double to 100,000 people. You are the public health official for the country now. You make the call. Can you sleep at night knowing that your sin of omission, your refusal to do anything, is causing an extra 50,000 people to die every year? Can you sleep at night with that? So that's why public health officials strongly recommend the flu vaccine. If you're a young person, and even if you think you'll be fine with the flu, if you are interacting with somebody who is very old, very young, or very sick, and you care about those people, like you do care if they live or die, then you should get vaccinated too. More flu myths. There's always somebody who says, yeah, I got the flu shot and I got sick anyway. I'm not saying they're lying. I'm sure they're telling the truth. I'm sure they really believe it. But remember what I started out this lecture with? What does the flu do? It causes these symptoms. But actually, no, it doesn't cause these symptoms. Your body causes these symptoms in response to an invader. The flu doesn't cause these symptoms. Why does your body do that? Because it detected an invader and it triggered the alert. What does the vaccine do? It mimics an invasion. It tricks your body into thinking it got invaded. So your body triggers the alert. So if you're feeling these symptoms after a flu shot, maybe it means the vaccine is working as intended. It's making your body think it's being invaded, so it starts making antibodies. It starts making memory cells. Not everybody feels as bad as getting the real flu. Every time I got the flu shot every year, I barely noticed it. There was a little bit of swelling at the injection site for me, but it never bothered me otherwise. And sometimes I wonder, did I get the real flu shot? Because it never feels as bad as a flu. But I guess for me, my reaction is not that bad. But I rarely get the flu. When I said I often get, I did say I get the cold a lot, but that's a totally different virus. Remember in lecture 2, I showed you the bell curve and how most people's experiences will probably be in the middle of the curve. Remember, the height of the curve represents how many people fall into this category, and then less people fall into the more unusual or extreme levels. So the person who says, I got vaccinated and I got sick anyway, it could be that they really did get the flu or the whatever the infectious disease that the vaccine was supposed to cover, but the vaccine genuinely did not work. Then they're going to be over here or here. Doesn't matter with the graph is just arbitrary, but their experience is rare because the vaccine didn't work. And the people who say, I didn't get the vaccine and I also didn't get sick, so therefore I don't need it, their experience might be here. Again, a small percentage of the population is like that, is experiencing it that way. And it's their life, their bodies, they're telling the truth. So they can do them, you do you, fine. But the question then is, where will you fall down? Which category will you fall in? You have a friend who's been throwing dice, and they keep coming up ones and twos. And and everybody accepts, everybody can see that it's ordinary, honest dice. But your friend keeps rolling ones and twos. And then they give you and then they say, go ahead, roll the dice. You're going to get ones and twos also. Is that true? Or do you have a 1 in 6 chance of rolling any one of the numbers on the dice? Similarly, a friend has rolled 5s and 6s every time they try. Does that mean you will roll 5s and 6s? Again, assuming that the dice are honest and fair. Well, there's a 1 in 6 chance that you can roll any number on that dice. So the question is, where will you end up when it's your turn to make that decision? I've decided that I'm always going to be in the middle because I can't prove it because nobody will ever know until the moment comes, the moment of truth comes. But so far in the past, I've always been middle of everything. I've always been average. I've always been regular, not unsurprising in terms of like my medical situation. So I assume that I'm always going to be here. So if a vaccine is recommended, which means the numbers of people who were benefiting far, far, far outweigh the rates of side effects as proven in multiple clinical trials in the past and even uses in the past years, then I'm going to take my chances. I'm going to roll my dice over here. That's what I'm basically saying. Is it possible that one day I'm going to roll a 20-sided dice and roll a natural 1 or a natural 20? Yeah, of course it's possible. But I have to make my decision assuming that my rolls are just going to be average. There are serious side effects to the COVID vaccine, and here they are. Well, as of 2023, so this is called the VERS, Vaccine Adverse Reporting Syndrome. I should bold that. And it's tracking the people who reported it. So there could be people who had adverse reactions but did not report it. But then if it's that mild that they felt it was not reportable, then it's going to be over here, right? So the vast majority are muscle aches, which is understandable. They just got a jab in the arm. It didn't actually say if it's generalized muscle ache or at site injection muscle ache. Tenderness, I'm assuming at the injection site. Headache, again, likely a body reaction to to what it thinks is an infection, localized pain, localized to the injection site. Allergic reaction happens to all medications, and there's absolutely no way to predict who will get an allergic reaction to a medication or not. That's why people are told to wait at the clinic for 15 minutes before they're free to leave, just in case there's an allergic reaction. 20% did not return to work immediately after vaccination, so it caused body aches or some of these things. And now for severe, serious adverse reactions, it was this amount. And then there's like 1.5% of people who took the vaccine, 100% did die. But then, as of 2023, these deaths were not directly resulting from the vaccine itself, but from the pre-existing comorbid condition. These folks already had heart disease, and then the stress of having COVID was the one last thing they couldn't deal with. Another example, measles, the measles vaccine, and people's complaints about the measles vaccine pretty much fall into these categories, and these are not complete. Like there are other reasons, excuses to not have the measles vaccine, but the ones I've heard of so far are, first of all, it's don't butt into my business, right? It's my decision whether I want to or not. So why should it matter if I don't get it vaccinated or my kids don't get vaccinated? Um, a lot of people saying that measles is not so bad and everybody gets it. Nobody died from it, basically what it is. Or no, sorry, nobody died from it. And in the grandparents' time, they had measles parties, which is they assumed that measles is mild, no big deal. So why not have their children get infected sooner rather than later? The idea being that when they are children, then they can be under parental supervision. Whereas if they get the measles later as adults, then they're who knows where they are, somewhere randomly in the world, surrounded by strangers. And then if they have a severe reaction, then nobody's there to keep an eye on them, right? So while they're still children, parents would have measles parties, which is if one kid did get measles, then they were all gathered together to make sure that one kid infected everybody else. And then the parents watched their kids closely to make sure they survived it, no big deal. So all these stories together told to you or whoever is out there makes you conclude, oh, I guess measles is no big deal. The thing is, before the measles vaccine, almost hundreds of people, 774 people died per year, according to the American History site.edu. Oops, misspelled that. Measles. Measles killed at a higher percentage rate than whooping cough and scarlet fever. Your pediatrician tells you that your kid has whooping cough, you're going to panic. It's terrifying disease. Watching your kid suffer from whooping cough is heart-ripping. Scarlet fever is scary to look at too. And measles actually kills more than that without the vaccination. So the thing is, at only this many deaths per year across the country in the 1900s, what was the population of the U.S. in the 1900s? U.S. population, 1900s. 1900 census was 76 million people. 76 million people. So not even 700 out of 76 million, move the decimal points. We're talking, I forgot the term for 0.00001 percent. I'm sorry, 0.001%. micro. It's a tiny, tiny rate. So that's why majority of the survivors lived, grew up assuming or knowing nobody who died from it. People all over the country are saying, well, I don't know of any kid in my neighborhood who died from it, or I don't know of anybody in my memory who died from it. So of course, they would think measles is harmless. Measles don't kill anybody, but it did. Now, before vaccines, there was nothing that can be done. It just happened. It's just a part of growing life. It's just a part of being a kid. So back then, this many deaths from this disease was acceptable, only because there's nothing they can do. But now we have vaccines, and now these numbers are unacceptable. Somebody lets this many people die from a preventable disease will get fired. Measles today, worldwide, estimated 95,000 people die from measles in 2024, which is the latest available numbers, the WHO.int. Most children, of these 95,000, most of them were children under 5 years old. Again, because even though vaccines are available, so the kids' access to vaccines were impaired. When vaccines are available, they estimate that almost 60 million lives were saved. So 60 million deaths were prevented. How do they know it was prevented if they didn't die? That's a exercise in statistics analysis that we're not going to get into here. Vaccinations decreased an estimated measles deaths from almost 1 million people, getting on to near 1 million people in 2000, and then in 2024, almost 100,000 people. So that measles is real. In the United States, last year, there were over 2,000 cases. Why? Because of the anti-vaccine movement. Of them, 11% were hospitalized, and then 3 died. And no, vitamin A does not cure measles. So what happened was the person who's supposed to know what they're doing, read a couple of articles that said people with vitamin A deficiency has weakened immune systems, and so were susceptible to measles. He therefore concluded, if a little bit is good, then too much is better. And when he told everybody the person who is in charge of healthcare in the United States, when he told everybody to not get the measles vaccine, and then reporters asked them, what are they supposed to do instead? He told them to take vitamin A supplements, assuming that if a little bit is good, then too much is better. What he didn't know is that excess vitamin A can easily become toxic, to vitamin A toxicity, and that can cause liver disease. So after his statements, parents in these parts of the country started bringing their babies in with liver disease because they overdosed on vitamin A. Now that I've showed you an example of how serious these topics are and how this job needs to be taken seriously, let's close out our lecture with these few slides about epidemics. An epidemic is a sudden rise in the number of cases. A pandemic is a sudden rise in the number of cases across natural boundaries. Used to be considered geographic boundaries, like how can a disease cross over oceans or mountains? Well, with airplanes, right? So now it's more about international borders. A pandemic is a disease causing multiple epidemics across international borders. An endemic, on the other side, on the reverse, is a disease that doesn't cause a spike, but it's sort of always there. It just never goes away. The community tries to wipe it out, but it just would not go away. Every year after year, there's a small percentage of the population that keeps getting it, either because new hosts new hosts are born every year. Other people move into the community every year, as well as people moving out, and so they haven't been infected yet. Anyway, it just keeps being there. A typical epidemic curve or infection curve is like this. These days, number of days is completely arbitrary. This is a hypothetical imaginary disease. It's not meant to be any specific disease. You don't have to memorize numbers. It's just the labels here. So again, the height of the graph is how many people were infected, and the horizontal axis is time. Anyway, around day 2, let's say, the first exposure happened. But then around day 6 is when the first person appeared at a clinic complaining of symptoms. And that span is called the incubation period. You know, when you incubate eggs at a farm, the eggs are laid, and then a certain number of days later, the eggs hatch. So the first exposure is the beginning, and then the first symptoms appear is the end of the incubation period. What was the incubation period for COVID-19? You've heard this number. It was told to you again and again and again during the lockdown, and the answer is 14 days. Again, one size fits all is not accurate. It was just the average one. Some people it's more, some people it's less, but they had to come up with some number without confusing the public. So they came up with 14 days from exposure to first symptom. That's incubation period. That's a question in your homework assignment, and now you know. This tiny little phrase here, the statement here, is all that's said in this entire slideshow. Only those of you who have made it this far in the video will know how to answer that. Oh, and of course, whoever Googles it too. So anyway, the first reports start trickling into the hospitals around the region, and then the number of people infected start rising. There's an upward curve as the number of people not yet infected far outweigh the people who are. And one person gives it to 2 people, and those 2 people give it to 4 people, and those 4 people to give it to 8 people, and 16, and 32, 64, 128, 512, 1024. You see what I'm getting at? As an exponential rise. At some point, though, the number of people not yet infected is starting to run out as the larger and larger percentage of the population becomes infected, and the curve tops out. So what makes a curve start to drop? The people who are infected start to get cured, or they move out, or they die. But the total number of people, the prevalence of a disease starts to drop as the number of people not yet infected start running out. Eventually, it reaches this level, and then what happens is it never really goes away. The number of new people entering a community is balancing out the number of infected people leaving the community, and so there's always like fresh fuel for the infection, and it turns into an endemic. COVID-19 is around here. It's now been several years since the beginning. It is now in the endemic stage. COVID is still out there. COVID is still killing people. It's still sending people to the hospital. Then why did they declare the lockdown over around here? Why was the pandemic is actually not exactly over. It's turned into an endemic, but the lockdown was officially declared over around here. What's going on with that? And this is what happened. So you have the basic infection curve here, and now let's apply to a serious virulent epidemic. Okay, so this top graph here, we're assuming no public health effort, either because they didn't care or nobody had their ability to do it, or there was no, yeah, I mean, there was no technology, like maybe this ancient times where they didn't have the concept of vaccines or social distancing or anything like that. Okay, so here's the incubation period as usual, and then the rate starts to rise, and this is a very virulent pathogenic virus, and it starts to hurt people, kill people. What's this red thing? The red line, let's say, is the capacity of the healthcare system. Number of beds, number of doctors, number of medications, and it's pretty much stagnant. I mean, yes, you can invest in more hospitals, hire more doctors, but that's going to take decades. Epidemics like gas themselves out in like a few years. So the capacity of the healthcare system is pretty much level. What happens when the number of people infected exceed and the number of people who seriously need uh, advanced medical care exceeds the capacity of the healthcare system to give it? What happens to these people? Well, they don't get care. They have this many beds. Another person shows up, needs a bed in a hospital, they don't get one because the beds are all full. They have this many doctors. More people show up needing doctors, then the patient to doctor ratio start to skyrocket. And these doctors need to go home, but they don't. They're forced to stay past their shift. They start getting exhausted, they get tired, they start making mistakes. Doctors get infected too, and so do nurses, so do ambulance workers. The whole healthcare system is now stressed beyond belief. And more people keep showing up with a disease. What happens to people who die and the morgue is full? What happens to them? Well, you've seen what happens to them. Has anybody noticed the refrigerator trucks parked outside of hospitals? So that's where the excess bodies were stored, waiting for space or waiting for somebody to get to them. Funeral homes were getting overwhelmed. Now, in ancient times, even before modern times, what happens to those dead people? They pretty much were dumped in the streets, mass graves. But now in modern times, with modern press, that's unacceptable. Leaving bodies in the streets is absolutely unacceptable. So they were kept in refrigerator trucks. And then finally, the epidemic peaks and uh, the curve bends over, and then finally it comes down until finally the number of people who have the disease falls below the capacity of the healthcare system. Is there any way we can reduce this red area? And the answer is to flatten the curve, which means this, in an ideal best case scenario, as the epidemic is detected, then public health efforts are initiated and ramped up so that the total number of people who are sick and need advanced care stays below the line. So everybody who needs care gets care. What does that mean? People who would have been infected here have to wait to be infected over here, and that's why the curve flattens out like that. So the span of time that the epidemic is happening is extended, but at least everybody who needs care gets care. So that's the trade-off. How do you flatten the curve? And the answer is masks, social distancing, vaccinations. All right, so this is the worst case scenario. This is the best case scenario. How did it happen in real life? Somewhere in the middle. We had refrigerator trucks. We had parts of society refusing to wear masks, refusing to get vaccinated, refusing social distancing. So the graph did spike above the capacity of the healthcare system. We had doctors, nurses, and ambulance workers working overtime, getting exhausted, getting infected themselves. The system was brought to the brink of collapse. So we've had one pandemic. Was it the first pandemic in recorded history? No, we've had many, many pandemics in the past. But this is a pandemic that hit us during our great social media revolution. And so it's fresh in our minds. It's the most well documented, not only from officials, but everybody else documenting their personal experience. So it could be the first in that. It's not even the first influenza pandemic. COVID-19 is a kind of influenza. It's like in the general category of it. There was the Spanish flu that is that there's an extra credit of the Spanish flu going to be published soon. And you see all the same things there, the social media, the masking, and the resistance to lockdown. And there's been, of course, there was the Black Plague that swept through Europe, and there was the New World plagues that swept through the New World, wiped out 90% of that population. So I would say pandemics are kind of nature running its course. It's just that, as you know, in our modern societies, we don't accept that. We're shocked that nature would actually still have some kind of influence in our lives. Anyway, will there be future pandemics? Of course there will be. Same way that life finds a way. All we can do is try to prevent it. But again, it's like trying to prevent a disease. Sometimes we're successful, sometimes we're not. And then if a pandemic really did happen again and hit us as hard as COVID did, then I hope that we will have learned enough of the lessons from the past so that we don't repeat some of those mistakes in the future. Here are some known diseases that are sweeping around the world. It rears up its ugly head from time to time. This one was in the news just recently. And so, again, we have to support our public health officials. This is not the time to impair their work, to defund them, to interfere, or to prevent them from getting what they need to be done. This is the time to help them get a handle on these before the disease impacts and harms more people. In general now, a new disease is pretty much just waiting around the corner. And here are some ways that a new disease can appear, such as the new disease was always there. It's rare in the general population, never really got a chance to burst out on the scene, but then something happened in the environment or the way we live our lives that suddenly gives it the open door it needs, and then it bursts into a epidemic spike. Some viruses and bacteria and other microorganisms are in the wilderness but had no previous human contact. But then humans constantly pushing out the wilderness, extending their range of civilization, eventually runs into eventually runs into it, whether it's pushing out new farm development in the Amazon rainforest, or drilling deeper into the polar ice caps, or letting the polar ice caps melt, and then parts of the wilderness that were there even before humans evolved, never had contact with humans, are now suddenly exposed to the air, and then is caught, infects an individual, who then takes it to the base camp, and then takes a truck or a ship to an airport, and then ends up at John F. Kennedy Airport here in New York, and then is in a subway seat near you that evening. Pre-existing microbe could have a mutation, and it suddenly makes it more virulent. How do we know when that will happen? We have no idea. Life finds a way. Mutations are totally random. You just can't predict it. All we can do is be on the alert for any unusual spikes in signs and symptoms, in hospital reports, and then get that DNA analysis as soon as possible to know what we're dealing with. One thing that public health officials look for are descriptive studies from clinicians, from hospitals. They can see then that something is up. We sure are getting a lot of this symptom from this area, and then some clever, nosy public officials will start looking in and then trying to see if this is a future pandemic bubbling up from the wilderness. Another possible source of a future pandemic is antimicrobial resistance. Now, just to be clear, an antibiotic only works against bacteria. You can't have a viral infection and ask the doc for an antibiotic. That just shows that you don't know what you're talking about. The best medication against a virus is an antiviral and an antiparasitic, etc., etc. Now, sometimes the doctor decides to give you an antibiotic for a virus, but that's because that disease was known to have open up opportunistic infections. Like you were suffering from a viral infection and make you more vulnerable to bacterial infection in the future. So they gave you and that's like one more thing you got to deal with, right? So the doctor gives you an antibiotic on top of the antiviral. But that's for the doctor to know and to figure out for you. Don't start medicating yourself. When you're given an antibiotic, for example, usually what they do is they start you in a broad spectrum. What that means is they don't know what it is yet. It's going to take 3 days to culture the specimen to know exactly what they got. So while we're waiting for the 3 days to know exactly what you have, they'll give you a broad spectrum, which is supposed to work on like as many different kinds of bacteria as possible. And it's basically to hold the line, to give you something until the specific pathogen is identified. And once it is, then they can give you a special antibiotic directed specifically against that bacteria. Antimicrobial resistance is on the rise, though, as antibiotics are misused either intentionally or accidentally. Then it gives rise to resistant forms. Mutations are totally random. We can't control it. It just happens. It's been happening before we existed as a species. It will continue to happen after. But what's happening is bacteria, for example, a bacteria that was supposed to be sensitive to an antibiotic, one day a random mutation causes one of them to be resistant. And resistant doesn't mean completely immune to the antibiotic. It just means it has a higher chance of surviving than its fellows. And if the antibiotic is misused, then as the antibiotic sweeps through the body and kills most of its fellows, this individual that's mutated, the resistance, survives. And then they are able to reproduce themselves. And now the next time the antibiotic is used, it doesn't work so well. One of the examples, a well-known example, is multi-drug resistant tuberculosis, which is down here. The MDR-TB. Now, tuberculosis is a terrifying, serious, deadly disease. We take it very seriously here at healthcare, but at least we have medications for it. However, for the past few decades, there's been a multi-drug resistant strain that's been sweeping the world, and it's not at panic levels yet. Not that I've heard of, but I'm not in the infectious disease department, so I don't know. But so far, I haven't seen that many news articles, health news articles, sounding the alarm about it. But one of these days, it could happen. But what do you do for somebody with multi-drug resistant tuberculosis? Isolate them, obviously, give them supportive care, and pretty much hope that they fight it off themselves. Because we literally have nothing to give them. We just pretty much just wait for them. Hopefully they fight it off on their own. they happen to be lucky enough to be strong enough to do it, or start preparing their next of kin for a possible death, and to explain to their family that there's nothing we can do. This bacteria is resistant to everything we got. The question then is, well, why don't you invent something new? They're trying, but new antibiotics, new antivirals takes years or decades to invent and then develop. And there is this twist where there's this twist out there where new antibiotics and antivirals are not that profitable. It's because they're not supposed to misuse it, that they're not used generally or often, and therefore there isn't that much profit in it. So there isn't that much incentive for big pharma to develop next level antibiotics. That's just capitalism at work. You've heard the phrase capitalism fixes everything. So that's how capitalism fixed this. It's not until enough demand is created, enough demand is discovered, that big pharma will finally do something about it. Why would anybody misuse an antibiotic? Well, patients who feel better and stop using their expensive antibiotics, right? Save the rest for later. But that gives the resistant strains a better chance of surviving this pass. And then they are around to populate the next generation. Corporate farms put antibiotics in their animal feed to prevent infections. And this is not waiting for the animal to get sick and then giving it to them. It's giving it to all of their animals in the beginning to prevent them from getting sick in the first place. That sounds like prevention, primary prevention, but you don't play that with antibiotics. That's overusing it, and that almost guarantees that resistant strains will come out. And that's a major worldwide corporate farms, not just the US, but around the world. They do this, and they are actually creating a lot of the resistant strains that are going through the world today. Some countries allow people to buy their own antibiotics without a prescription, which means they're using the wrong antibiotic for the wrong disease. And all they're really doing is not helping their current infection, but also encourage, because they don't use the entire prescription. That doesn't exist, right? So they use it piecemeal to save money, and again, they almost guarantee that resistant strains are created. This cartoon panel is a illustration of it, so I hope it's useful to you. But you know what? I've already overstayed my welcome. Let's go move on to the last slide of this lecture, which is not even a recap because we've covered so much today, but just make sure you understand these concepts at least. So thank you for making it all the way to the end here. Yes, it's been a long lecture, but it's a major topic when it comes to public health concepts. And so congratulations. Wish you the best of luck, and you'll hear from me next week.